So thank you very much for coming here. I'm Professor Hans, and I will share this session with Professor Karen Hint. We both from an academic background, and not only from an academic background, but we're also part of Medimaps. Karen as a clinical affair, and me as a CEO and founder of Medimaps. But we'll give more twist of the academic side here, just tell you some insight of what the next generation in bone health, what we're moving to a 3.x version to the next version, and what is TBS generally speaking, and give you some kind of overview. Even though you have already some good idea with what is written on the wall, where we have a lot of countries, guidelines, more than 4 million patients every year, and 1,400 per review publication and so on. But we'll go a bit more detail in some of the aspects. So that will be the overview of what we'll discuss. So I've been smart to escape very rapidly by leaving my colleagues mostly make most of the talk, but at least I give the introduction about Medimaps. So Medimaps been founded mostly as a spin-out university a bit more than 10 years ago in 2012 for Medimaps Group. What is important is the mission is really for us not to develop a product. We're not selling a product. We're not selling a commodity. We're selling a medical solution. While I'm saying that, coming from an hospital environment, and I'm still co-managing the Center of Bone Disease in Lausanne University Hospital, for us it's very important to identify the clinical gap. A real one, not a fake one. A real clinical gap which is unanswered today. Develop a solution. But if we develop a solution that fulfill a clinical gap, but is not seamlessly integrated into the workflow. Being doctors, some of you, we know that we don't like to change habits so easily. So that means we have to sneak into the habit of the doctors to be totally seamlessly integrated to improve the medical acceptance. So if you work really toward the patient, you solve an issue, and you make it easy for the doctor to use it, then the medical adoption will be important, and then your product can really take off, even though we still take time. Because when you do a study in France, the Italians say, yeah, but that's the French people. Let's do it our way. We do that in Italy and then the Germans say, no, we want to do it that way. And so at the end, you will have to multiply a lot of things. And that's part of the medical acceptance. So it takes almost like 10 years, at least 10 years, to have a full medical acceptance. And that's the pathway we've been taking for Medimaps. So we are really patient-centric, innovation where it really matters most from the clinical outcome, and elevated the standard of care worldwide. We really want the solution not to be local, but for the benefit of all the patients around the world. So now if I show you something in osteoporosis, many of you will recognize what we call major osteopath fracture. When I'm talking about major, it's not like all osteopath fracture, but the major one is the spine, the hip, humerus, forearm. And when we talk about fragility fracture, we're not talking about like having a car accident or falling from your bike. We're talking about almost sometimes spontaneous fracture. I'm talking to you and suddenly, ouch. Your hip has been broken. Or you take your children in the arm, boom, vertebral fracture, or lifting the window shield or something. So like a stupid thing from the day to day can lead to those major fracture. And what we say is so silent before it's happened that a lot of people been undiagnosed or not been diagnosed properly. And for those who've been lucky, been preventive and been sent to bone densitometry, we know that we have 37 million osteopath fracture, major osteopath fracture every year, which represent one fracture every 3 seconds above the age of 55. Which means if you take all the age, we talk about 3 fracture every second, 1 fracture every 3 seconds, sorry. So that's huge, and the cost associated that is around 125 billion Swiss francs per year. Is huge. So what is important is fracture is not just a consequence of a normal aging process. There is, of course, a primary osteoporosis with aging is an impact, but you also have secondary cause of osteoporosis, which is related to lifetime, treatment, consequence of anti-aromatase or corticosteroid or some other disease and stuff like that. So now, if you get lucky, you've been sent to DXA. The DXA with the measurement of bone is the gold standard as of today. Density represents roughly 60 to 70% of the overall bone strength, but we still have something is missing. And what we know, despite the fact BMD is the gold standard, we still have about up to 75% to 80%, depending on the study, of patients with major fracture that occurred in a non-osteoporotic zone. So in other words, you will tell the patient, oh, you're not osteoporotic, she get out, boom, fracture. Say, how come? So BMD is very important, but BMD is not enough. In order to go further, we need to have a bit more insight into the bone and to take somehow the structure into the bone into account. If I show you here, who's the one who most likely going to fracture? If you have here two women around the age of 68 with about the same BMD, which of the two will fracture? Why? Because you have 0.01 gram difference? They both have the same age, about the same density. I could have reversed the image or whatever, but most of the time, and that's exactly the problem, when we say that you have a lot of patients with the same BMD, some will fracture, not the others, with the same similar image. But if you look at the underlying structure, that can be quite different. And I like to do some exercise with my hand, so it's just like, try, maybe not that easy. You may have the same density, but the underlying structure can be different, while the density, areal density, will be the same. So same density, underlying difference. And because the underlying structure will be different, the biomechanical strength of the bone will be different, and one will fracture, why not the other, despite the fact they have the same density. So you just imagine, the Eiffel Tower, for example, with arthrosis. Or, to my colleagues who's sitting on this high chair, just imagine you're sitting on those chairs, we remove the little metallic bar below your feet. If we remove that, you'll be sitting on the floor. Okay, so the structure will make a big difference. So in other words, you need both. You need the density and the structure to have a more global estimation of the bone strength, the bone health, is needed to be more precise for your patients. So the question, can we go beyond the BMD? And I will let my colleague, Professor Karen, to answer these questions.
Thanks, Didier. Welcome, everyone. So I'll take over, thank you. So we have the answer, we have the missing part of the puzzle. BMD is only 50% of what we're looking at. And with DXA, we can get the 100% if we add TBS. This is how TBS was born. Medimaps identified the clinical challenge and found the solution. So trabecular bone score is a validated surrogate of bone microarchitecture and has been validated since 2008 against gold criterion methods such as micro-CT, bone biopsy. And we have been enhancing the clinical practice of osteoporosis assessment and diagnosis since 2012. So very rapidly after that validation, we were accepted into clinical practice. And actually, if you're in the US, it's quite interesting to know that we have a blueprint for reimbursement. So we've been reimbursed via Medicare and other insurers since 2022. Again, applying a blueprint potentially for across the rest of the world. And interestingly, we have a new software which we are releasing this year, 2025, the new generation TBS Osteo, which I will present in a few slides' time. So as you can see here, we have the DXA scan, we have the BMD image, and we also have a TBS image. So these two values can be derived from the same scan, from the same patient within 3 seconds. And you can see the validation with the microarchitectural parameters from gold standard criterion. With the TBS, we have 3 categories of assessment. We have a normal TBS if your bone microarchitecture is good. We have partially degraded TBS if your microarchitecture is somewhere in the middle. And then we have degraded, and this means your bone microarchitecture is failing. And when you put this together with BMD, you're really getting a full picture for that patient. So going back to the problem Didier announced earlier in the presentation, we know patients fracture despite having normal BMD, and this challenge has continued for 3 decades. So why aren't we doing more about it? And this is why we're seeing the growth and popularity of TBS. This is because we can see that the addition of bone microarchitecture to a diagnosis for a patient can identify more patients at risk to make sure that these patients then go to receive the treatment that they need. We have 2 studies here. We have a big population study conducted in Canada several years ago, and this population found 10% of women who fractured because of osteoporosis had normal BMD, so not even osteopenic. And from that 10%, 50% of those patients had a degraded TBS. Now, had those patients been identified with TBS at the time, they could have been moved towards an intervention and potentially a treatment. And we have a further study here which just replicated those findings. So 8% of fracture liaison service patients had a normal BMD, but they had major osteoporotic fracture. This creates a clinical challenge. How do we identify these patients? Adding the TBS can identify the hidden bone fragility in around 40%. So you're really fine-tuning the assessment in the same method without needing to use the CT. So within the same scan, you can derive the TBS and find hidden bone fragility. Here is one example. So we talk about primary osteoporosis in postmenopausal women and associated with aging. We can also look at drug-induced bone fragility. So from those common interventions, glucocorticoid steroids, which are used for many, many diseases, these steroids are effective in treating the disease and managing the disease, but actually they can increase the bone fragility risk by 6-fold. In this study, you can see exactly the difference. In these patients, BMD is not always effective, but the TBS in addition can identify more patients at risk. And this is because of the pathophysiology, the mechanics behind the drug-induced bone fragility can impact the scaffolding of the bone, more so than the mass. And here we are. So this is, if you have the TBS software, this is what you'll see. You'll see a 9-zone bone fragility index. And what this does is combine the standard World Health Organization diagnostic criteria of BMD. You've got your normal osteopenic and osteoporotic BMD in patients. And then you combine with the TBS, and you have your normal partially degraded and degraded. And by putting this all together, we can identify at least 30% more patients who will fracture because of a degraded bone microarchitecture as well as a degraded BMD. This was validated in over 30,000 postmenopausal women. And additionally, if we're looking at secondary osteoporosis, then we're identifying up to 40% more patients who will fracture. And these are 40% more patients who then can go and get the treatment they need. So we can reduce that burden of fracture. Here we are, and this is the expansion of TBS across the world. We're very proud to say that we have over 4 million procedures of TBS globally every year. We're accepted now, we're clinically accepted in over 90 countries. We are underpinned by almost 1,500 peer-reviewed scientific publications in at least 30 guidelines, and in USA we've got that critical reimbursement, again setting the blueprint for the rest of the world. Here is the big paper that was published in 2023, and this paper really cements TBS in the global acceptance in clinical practice. And we have, it was an intensive review conducted by 96 published studies and resulting in 22 expert statements, which can help guide your integration of TBS in practice. So any questions you might have about how to proceed, it's all in this paper. And we have sections in this paper with expert statements covering the application of TBS for primary osteoporosis, for secondary osteoporosis, and importantly for treatment. And I'm not covering it in this particular presentation, but if you want to talk to me afterwards, or Didier, what we can do with TBS is by bringing the TBS and the BMD together, you can fine-tune the treatment decision-making. So we're moving towards a more personalized treatment strategy, tailoring the treatment to the patient's overall skeletal profile, which is quite exciting. You can read more in the paper. For those, we're at a radiology conference, so I wanted to include this study as well. You might know from DXA that BMD can be artificially elevated in the presence of degenerative changes such as osteophytes, common with age for osteoarthritis. This study was conducted with CT in spinal patients, and what it found was the BMD was impacted by those osteophytes, degenerative changes, which means you can't rely on the BMD in these patients. But you could rely on the TBS because the TBS is generally unaffected by degenerative changes. And this is further included in the ISCD clinical guidelines published last year. So here we are, TBS Osteo next generation version 4. I'm very, very happy to pronounce this to you. We've been waiting several years. This is a major leap forward. We do bear in mind that the evidence already has proven that TBS is an accepted and clinically validated algorithm. But at Medimaps, as you probably got from Didier, we're always enhancing. We always want to do better. We can always do better and push the field forward. In doing that, we add an additional feature. So when you're conducting your DXA scans, you know the soft tissue in front of the spine can sometimes create some noise on the image of the bone underneath. And with that, you may have a slight inaccuracy of the bone that's been measured there, especially with textural analysis. And what the V4 does is, well, the V3, we use the BMI to adjust for that. And that's okay, and it's been working fine, but actually we realized in order to expand our patient eligibility, so we can include patients type 2 diabetes who have a lot of mass in the front, anterior to the spine, or we can accommodate people with variations in body size, such as your elite athletes who are at risk of fractures. We did that by applying a direct tissue thickness measurement from the DXA scan itself. So all of the time we're becoming more accurate. What this means is we can expand the patient population. And what this means is this year, potentially early next year, we'll be moving towards pediatrics. So there'll be a pediatric enhancement available because of this expansion of tissue thickness range. Here is an example. We've got a type 2 diabetic patient who may have a normal BMI but has high central adiposity. And we also have your elite athlete on the side who has high BMI, a very low tissue thickness, and high muscle mass. So we know that TBS V4, the new generation, is going to be suitable for both of these different patients. And we have a lot of confirmation in that with the recent FDA and MDR approval. What TBS Osteo also does is we're moving forward for central management. We know in busy clinical practice, it can be quite difficult if you've got your DXA scans across different departments in the hospital or across different hospital groups. What TBS Next Generation does, it enables you to centralize the management of those scans across the different DXAs. So you can access that maybe from your own laptop or wherever you are in the hospital. You can see your patient results from multiple DXAs, not just the TBS, but also the BMD at the same time. We also have a smarter way to stay ahead. Now, this is financially smart because what we've introduced is a subscription model. And this is based on listening to our customers, what our customers want. They want access to the latest innovations. They want an affordable subscription, which has those continuous software improvements. So we're now happy to introduce a more flexible model, introducing that subscription model, which makes sure that you, if you subscribe to the TBS Osteo, you're always guaranteed to be ahead of the field, and you will automatically be eligible for those updates, including the expansion to TBS Pediatrics and TBS Hip, which is currently in validation. So I can move on to the Medimaps AI-powered ecosystem. We don't stop there. We don't stop at DXA. We want to do better than that. We want to close the gap. We want to identify more patients proactively who are going to fracture so we can prevent the first fracture. And by doing that, we have a whole ecosystem. In the middle, we've got TBS Osteo, which I have just presented to you earlier. And we now have TBS Reveal, which is in the development stage. And I'm very happy to say that I'm looking after the team, and we're working very hard. We're in the final stages of validation. What this software does, it enables opportunistic screening of bone fragility from X-ray. And this, I'll go on to why this is different to what others are offering in a minute, but it enables us to be more proactive. Those patients that can then be triaged to DXA. We also have TBS Ortho, which is also in validation. This will provide a tool to improve the bone optimization of patients before surgery, because we know bones that are weaker, bones that are more fragile, can potentially likely to fail during surgery, which can come with increased costs and a lot of pain for the patient. We want to prevent that with TBS Ortho. So here is TBS Reveal. We are the only AI opportunistic screening tool for bone mass and bone microarchitecture. There are a few others out there, but they will only screen the bone mass. We consider the bone microarchitecture, which is really the golden key for having an overall assessment of a patient. We use risk factors not only from AI, we use image features from the X-ray image itself, and also clinical risk factors for osteoporosis. What we want to do is fast-track high-risk and very high-risk patients for urgent DXA referral. And our model has been developed on over 25,000 image pairs to combine the X-ray with the DXA ground truth for BMD and bone microarchitecture TBS. We can apply this technology in any of the X-ray scans, which include at least 2 vertebrae. And this is where the strength of our validation is. We're not stopping there, we're expanding, but we're getting this one out first. And here are the results. So far, excellent results. And you will see what we are doing here. We are focusing on maximizing specificity and maximizing the precision of L. And by doing that, we're not funneling many patients through for DXA, because if we were to do that, it would become unsustainable. And this is one of the challenges with AI, that it can become unsustainable if you're over-referring patients. So we're really targeting those patients in group 9, in zone 9 there, the patients who are at imminent risk, who are very likely to fracture within the next 2 years probably. And then what we also do, if we're not capturing those patients in 9, we've got confidence that if they're not falling in 9, they will fall in the L. So they will still be patients who are clinically needing a follow-up. And with that, we call that the precision of L. So we're different, where we're not funneling everyone through, we're being strategic, we're making sure those patients are getting referred the right patient at the right time to get the right treatment that they need. So in closing, why choose TBS? We're trusted by experts around the world. We are been validated for over a decade now, Didier, haven't we? Yeah. The strength is in the clinical validation. We are constantly innovating. Unmatched accuracy, future-proof solution with our subscription-based model makes it very affordable. It's seamless clinical integration. We have a blueprint for reimbursement. I'm very happy to talk to you about that after the presentation. And we're built for expansion. We have an ecosystem. We don't stop here. We are committed on this journey to improve the assessment of bone fragility and management. Thank you for your attention. Any questions?
Maybe to give you one more thing, when we talk about clinical validation, we have one paper on TBS coming out every 2 days worldwide. So that means it's not like being validated in the past, it's not changing. One paper every 2 days. It's not one fracture every second, but it's one paper every 2 days. So that keeps comforting, and you know what? It's out of control for us in the sense that many new applications popping up from researchers around the world. Some of the pathology we couldn't even imagine. Even some rare disease like HPP patient just came out, and we have an oral presentation at the World Congress by one of the key leaders in the world in HPP. So hyperphosphatasia, thanks. Well, I would just make it up. But anyway, it's very important because the balls keep rolling. It's becoming bigger and bigger and bigger. And when we talk about TBS Reveal, so the plan is to launch a TBS Reveal at this RSNA this year. We go to the FDA over the summer, and even for that, we already have external validation, because what is important in AI is also generality, and part of the development include minorities in our development, and then external validation for this on different countries around the world. Do you have any question? Yes.
The tool of detecting the risk of fracture on X-ray, at least I think that this is what the software does. It put a degree of risk according to the AI analysis. Is it included in the new version of TBS, or is still under research?
No, that's what I say. This is what we call TBS. So TBS Osteo is the one we use in clinical practice, which is in more than 90 countries, that have been sold for the last decade, and more and more and more. And we have more countries coming with reimbursement. Okay, so that's one thing. It's really, for example, in US, the level of reimbursement is a game changer, because we're just like almost doubling the reimbursement of DXA in this country. And more countries are following up. So TBS Reveal is a different product than the one where we already present some data, and then the one will be released at the RSNA this year, at the end of the year. So different product, but still go within the patient journey. What's important for us is not to go jump from mammography to bone or whatever. We're bone specialists. We've been in the MSK field for 35 years. So that's where we excel in really our expertise, and that we want to complete the patient journey. We want to capture part of the 70% of the people being never referred to bone specialists. And later on, we know some of them will be sent there. We know even if we detect fracture before it occurred, we're going to give the appropriate treatment, but appropriate treatment just saving 50 to 80% of people, avoiding a certain number of fractures, but not all. So you ended up in a fracture. And in a fracture, from an orthopedic standpoint, you want to be sure you don't have periprosthetic fracture or revision or whatever. So you want to be sure before putting something in a bone, what is the quality of the bone in terms of density and structure. And that's why we're just covering the whole patient journey as Medimaps, and more to come. But I would say in 1 year from now, you will see we had more things around that and around the ecosystems around bone and muscles and so on. Arnaud.
Do you think that TBS Reveal will generate more DXA exams, and did you estimate already the percent of more exams?
First question, whether or not it will generate more DXA exam, the answer is yes, because that's exactly why the idea is to tackle the number of undiagnosed person by referring more patients toward bone health assessment, whether it's with DXA or something else, but really that the idea is really to send more patients, funnel more patients toward the bone measurement. How much? I've been checking this morning in my crystal ball, and it didn't want to give me an answer. So, but even just to make like a rapid mathematic, everybody have an X-ray in his life. Since we're focusing on a very high risk group, what we're estimating, if you do like in a big regular center, you will need 1 million X-ray or something like that per year, or sometime big or whatever. If above the age of 50, 16% of the people will be here. So let's be conservative, let's say 10%. So if we move 70 to 60, it's already moving the field of DXA from 30 to 40, which is like almost 40% increase. So that's huge. That's huge.
We'll need more DXAs. Indeed.
So the idea, and I will be sorry for you, Arnaud, is not for us, is not the idea to have more DXA, is to have more patients being properly handled. So obviously today the gold standard is DXA. It could be something else or whatever, but the idea is to have more patients treated because it's a silent disease. Yeah. So it's silence until it hurts. And it's when it hurts, it's too late. And the cost of it exceeds the stroke. Well, everybody talk about stroke or some other things and so on, but in reality, osteoporosis is by far much costly for the society compared to stroke and some other disease. But since silence, why should we care about it? We don't want. We prefer to keep that under the carpet. But when people complain when it's happened, and I can tell you, unfortunately, also seeing my mom having like a multiple vertebral fracture on anti-aromatase, their life becoming the end of the shoes because they're just like that. There's nothing else they can do about it. And at that age, we can't do any vertebroplasty or whatever. So the idea is just to act before it's too late, because we're living longer and longer. But what's the point of living till the age of 90 if your life becoming a nightmare? So the idea is like healthy aging. And in order to do healthy aging, is try to act before it's too late on many of the diseases. And bone health is one of them. Yep.
If I use a TBS Reveal on a X-ray, the result is the same of TBS Osteo, or I have to do another DXA scan?
We could make it the same, but the idea is not to make it the same for two reasons. First of all, because we don't have the same resolution. So for now, with a TBS Reveal, we won't give a value. Will give a range of the likelihood, the probability of being at the default bone microstructure and stuff like that. So that means we'll give you like a quality bone fragility index combination with a 95% confidence interval, like in a sense that, you know, medicine is not like this. You have variability. Giving one single number will be desperate. That means it doesn't reflect reality of medicine. So the idea is say, okay, what is the likelihood of that result? And that result might be overlap between poor quality and this zone, but at least you will see the overlap by this confidence interval. If it overlap by 10%, you know that at 90% you'll be sure that will be in that zone. And that's why the L precision is important, because we know that majority of the people who are not in this zone, then we failed the DXA to define that zone, will be at 90%, will be in the L zone, which is very reassuring at a very high level of probability.